And now I'd like to introduce Dr. Gary Klasser, Professor of Diagnostic Sciences at the LSU Health Science Center School of Dentistry. Dr. Klasser, I will turn it over to you.
Thank you very much, and I'd like to thank the Facial Pain Association for giving me this opportunity to speak to everybody regarding dental care for the neuropathic pain patient. As I go through the presentation, if anybody has any questions, queries, comments, please feel free to email me. You can see the email on this title slide. It's in yellow font. I will certainly pay attention to the emails, and I will try and get back to you if, in fact, you have any questions, comments, or queries in a very timely manner. So over the next 45 minutes or so, we're going to talk about how does dental care work, if you will, or influence, or why is it important for the individual patient who unfortunately is experiencing neuropathic pain. So to make sure that everybody is on the same page, what is pain? And the International Association for the Study of Pain has a definition. This was recently revised in 2020 because the previous pain definition was written in 1994. So what is pain? Pain is, according to this organization, an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So you may question, what do they mean by potential tissue damage? Think about those who are very fearful of dentists. As you're having a problem and you were reluctant to see a dentist, and a spouse is taking you to relieve your symptoms that you've been experiencing, you may be feeling pain as your hand is on the handle of just opening the door to visit your dental practitioner. So therefore, it doesn't have to be actual damage, but certainly potential damage. And myself as a dentist see this on a daily basis. And what this organization did, accompanying the definition, they wrote several notes that I think are very important in reviewing because it puts pain maybe in a different context in which you're potentially thinking. So always remember, pain is a personal experience. In other words, the pain that I may feel with the same stimulus as you may be completely different. And it is certainly influenced by biology, our psychological makeup, and certainly the social factors that we're all exposed to on a daily basis. Pain and nociception are very different phenomena. Pain cannot be inferred solely from the activity in the sensory neurons because there are many, many factors that influence pain. In true technical discussions, pain is only sensed when it reaches your somatosensory cortex. In other words, as pain ascends from the periphery to your central nervous system, it undergoes a lot of influences that can be both excitatory and inhibitory until your higher centers of your brain make sense out of the sensation that it is now trying to process. So certainly our memories can influence pain, where nociception is merely the transduction, if you will, of a unpleasant sensation from the periphery to the central nervous system. Through their life experiences, individuals learn the concept of pain. And we know how parents can influence their infants and child's pain experience. If you're a parent who is overly protective, overly concerned, react hysterically when your infant happens to fall down, that child will take those experiences, incorporate it into its central nervous system, and when they grow up, they in fact may be fearful of minor incidences because of the way you reacted to their pain experience when they were in their infancy. A person's report of an experience as pain should be respected. You cannot say, oh, if I have an 8 out of 10, if we ranked it on a numeric rating scale, and you had a 4 out of 10, it's unfair and it's inappropriate to say that I have double the amount of pain, because going back to the first statement, pain is a personal experience and it has to be viewed in the context of that individual's personal life events. Pain is usually adaptive, especially acute pain. It may have adverse effects on function and social and psychological well-being, which is very common with chronic pain. So just very briefly, I consider acute pain good pain. If you were to put your hand on a hot stovetop, you are not going to sit with your hand on the stovetop going, what is that weird smell? No, there's going to be a message sent very quickly from your hand to your brain to activate your muscles to remove your hand from the threat of continuous tissue damage. Therefore, it's adaptive. There is a genetic mutation where people lose the ability to feel pain and they just don't live as long because, again, they would keep their hand on the burning stove. However, if you have chronic pain is bad pain because it certainly greatly affects how you function, how you socialize, how is your psychological well-being. You may become hypervigilant. You may catastrophize. You may get involved in fear avoidance. You may have even low self-esteem, all because of chronic pain. A verbal description is only one behavior by which we can express our pain. The inability to communicate does not negate the possibility that a human has pain, nor when we do animal studies, because we are able to observe particular behaviors in the animal world, understanding that they're also experiencing the concept of pain. So I think it's very important that these notes are associated with that initial definition from the International Association for the Study of Pain. So concepts that we need to understand are, what is neuropathic pain? And again, the IASP said, pain caused by a lesion or disease of the somatosensory nervous system. So for those individuals who have trigeminal neuralgia, the neuropathic pain, the neuralgia, may be related to a blood vessel in your central nervous system that happens to be leaning on the trigeminal nerve root. Individuals who have multiple sclerosis have a demyelinating or a dysmyelinating condition. And again, that alters the normal somatosensory nervous system. So neuropathic pain, in its truest sense, according to this definition, there's a lesion or disease associated with that. So when we look at this graph, the nervous system, because of having a lesion or disease, in fact, has the particular pain associated with it. There's certainly an immune response. It's both spontaneous and stimulus dependent. It's associated with amplification of sensory information, and it can occur because of both low and high intensity stimuli. So when we look at the graph here, and this particular, you can see with my cursor, this is no stimulus. when you have neuropathic pain, you can have a certain amount of pain from it despite having no stimulus. If there's a normally non-painful stimulus, again, I'm going to use trigeminal neuralgia, the wind just blowing across your face may in fact be a painful event. And now if you have a little stimulus, you have a little pain, and more stimulus, you have more pain. So neuropathic pain is maladaptive, and it's often persistent, basically because of abnormal amplifications maintained independent of the lesion or disease. There's another term, and this is from the work of Costigan, where there's something called dysfunctional pain, and it's amplification of the nociceptive signaling in the absence, that's the key word, of inflammation or neural lesions. So when we look at the pictures of the bottom of the slide, we see a root canal done, and it's very nicely done, but that doesn't mean the individual cannot be experiencing pain. Or on my right-hand side, where you see the placement and a well-placed implant, again, everything radiographically looks very, very sound. However, that does not mean this person can't have dysfunctional pain. So what is dysfunctional pain? Again, no known structural nervous system lesion or active inflammation. Again, it can occur spontaneously. It doesn't need a reason to exist. And it's stimulus dependent, very similar to the previous one. So again, without any stimulus, that tooth with that very well done root canal can have spontaneous pain. Again, because it's spontaneous pain, even though there's no stimulus, you're not touching the tooth, you're not eating on that side, you can still have pain. And again, if I were to maybe palpate the area very lightly, I may have a little pain. And if I palpate the area more vigorously, I may have a lot of pain. This again is maladaptive, and it's potentially persistent. The IASP then came up with a term called nociplastic pain. And it's very similar to Costigan's definition of dysfunctional pain. And they basically say it's pain due to an altered nociception, despite having no clear evidence of actual or threatened tissue damage, which would normally cause activation of peripheral nociceptors. And there's no evidence for disease or lesion in that system. So why would somebody be having pain where everything, both clinically and radiographically, looks quite normal? They also added two other terms, and we won't get into this for this presentation. They used the term, or adjectives, if you will, algopathic and nocipathic. And I bring these up because if you look at literature as somebody describing this phenomena, these terms may also be used in addition to the term nociplastic. So let me kind of go through a case report, and the case report is going to demonstrate a dilemma that both the dental provider as well as the patient may be in because of a previous experience of a neuropathic pain. So the patient presents, it's a 56-year-old female, presents to a dental office with an acute dental pain. Remember, acute dental pain is good pain because it is irritating enough that it forces individuals to seek treatment so there's not more extensive tissue damage. And they have this acute pain in the left mandibular first molar. This individual, over the past several years, has not received any routine dental care. So this is clearly an emergency appointment with the acute pain pushing the individual to seek assistance from a dental provider. The history is 3 years ago, in other words, 3 years prior to this acute pain, this patient experienced multiple daily episodes of spontaneous pain, induced pain, in other words, stimulus-induced pain, or both on the left side of her face following the distribution of the left mandibular nerve, the V3 branch of that particular nerve. At that time, in other words, 3 years ago, the pain was intermittent. In other words, it comes and goes. It was severe. It was sharp. It was electric-like and lancinating. And it had bursts of extreme short duration, lasting only seconds to approximately 1 minute. So for several seconds to 1 minute, this pain was bringing this person to their knees because it was so extreme. The patient figured out, if I avoid any form of stimulation to this area, then this would decrease the number of experiences of this pain. So she was trying to avoid any triggering events from these excruciating episodes. A comprehensive history and examination was done. Imaging was performed to rule out any central nervous system pathology. All imaging was rather unremarkable. So a diagnosis was provided of trigeminal neuralgia due to a left V3 branch. The patient was placed on nerve membrane stabilizing anticonvulsants, and to date, the medication controls the trigeminal neuralgia, whereby she only experiences 2 to 3 brief but painful episodes on a weekly basis. That is much better than having multiple episodes throughout the day on a daily basis of this extensive pain. So that's her history, and this started 3 years prior to this acute dental event. So currently, her medical history is positive for hypertension, high blood pressure, hypothyroidism, and she also has intermittent low back pain. However, the good news is all these conditions are being treated very adequately by her physician, and they're not really a main concern of hers because, again, her physician is very adequately managing these other conditions. Clinically, the dental exam revealed no problems with any soft tissues. So there was no abscesses, there was no fistula, there was no sinus tract. The tissues, soft tissues, looked fine. From a dental perspective, looking at the hard tissues or the teeth, the left mandibular permanent first molar has a large filling in it that responded equivocally, didn't respond positively or negatively to what we do in dentistry vitality testing or any thermal challenges. A percussion on the tooth was unremarkable, and there was no evidence of any radicular pathology when dental radiographs were taken. So the dentist felt that the proper treatment for this tooth is to have a full metal crown, and in that way, it would protect the integrity of that tooth. Well, here's the problem. The dilemma is a dental intervention has to be done. And for all of you who are aware, when there's an invasive dental intervention required, that means getting a needle with local anesthetic and then some preparation of the tooth. And the reason why dentists provide local anesthetic, because if you didn't have it, it would be a painful event because the second layer of a tooth called dentin is quite vital. So now what does the dentist do? Does he or she go ahead and provide the dental intervention? Do they not? Is the patient comfortable with that? Is a dental intervention going to exacerbate this very well managed case of trigeminal neuralgia? Is it going to make the trigeminal worse? So this is a real dilemma for both the dentist and the patient. So hence, there definitely is, when individuals have neuropathic pain or nosoplastic pain, there's certainly a dental care connection. Dental interventions may cause nerve irritation and or more damage to an already system that isn't functioning properly. Clearly, not everybody has nosoplastic pain. Not everybody has neuropathic pain. So something is different in the population who has these pain conditions, i.e., their nerves are either dysfunctional or dysregulated in some way, shape, or form. The dental intervention may pose a risk for reactivating the initial pain. Clearly, this female does not want to go back to where she was before the membrane stabilizing anticonvulsant was able to manage her trigeminal neuralgia. The dental intervention poses the risk of exacerbating or aggravating the ongoing condition. So she doesn't want to go back to, I only have severe pain 2 to 3 times a week, to maybe having severe pain 2 to 3 times per day. So the dental team needs to modify their dental interventions to minimize the potential adverse consequences in these very unique circumstances. So what do? It's definitely, as I say, a question mark for both the dentist as well as the patient as to what is the best strategy to provide the intervention to fix the tooth without influencing my current neuropathic pain condition. So from the patient's perspective, patients with current or controlled neuropathic orofacial pain understandably may be very reluctant or hesitant to participate in any activity or undergo any dental intervention that involves manipulation to these hypersensitive areas. That is maybe one reason why this individual has not undergone routine dental care and why she presented as an emergency. Because of this particular slide, she may have been fearful, I've got things under control. I don't want to go back to where, or the point in my life where things were not under control. Therefore, I'll just avoid anybody who might have a negative influence on what's going on in my oral cavity. From the dental perspective, patients experiencing neuropathic pain will require dental interventions on an acute basis. Things happen that we don't want to happen. Fillings break, crowns need to be redone, teeth need to be cleaned. You want to make sure that your gingival, your gum tissue remains healthy, your bone levels are maintained. So whether people like it or not, you're going to need dental care, whether it's acute dental care or ongoing dental care purely for maintenance, and that means invasive procedures. Avoidance may occur due to the fear of, unfortunately, reigniting the original pain or amplifying their current pain. So the patient may say, you know what, if I don't go, I'm not going to take the genie out of the bottle because it took so long to put the genie into the bottle. So what can happen? If one avoids dental care, they could end up with having or resulting in progressive dental disease. They'll then have these barrages of nociceptive input into a system that is dysfunctional or dysregulated, and that could very likely reignite or intensify the central sensitization that is amplifying the nociceptive signal and keeping, unfortunately, the pain alive and well. So effective oral health maintenance may reduce the need for invasive dental interventions. In other words, if the road to periodontal disease is caught early enough, then you won't have periodontal disease and you won't require the more invasive prolonged therapies that are required. The added benefit reducing the patient's risk of developing complications associated with the neuropathic orofacial pain. When invasive interventions are required, it is the utmost importance of the entire dental team to recognize and understand these issues and to select the least invasive approaches. So the key is, in anything, diagnosis, 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 because the diagnosis from your dental provider will produce, if you will, a blueprint onto which a strong foundation to build a house. And I tell all my students here at LSU, you cannot provide an intervention, regardless of what the intervention is, until you have a diagnosis. So take the time, take a thorough history, do a comprehensive examination, use adjunct imaging studies or even blood studies, and then you can develop a proper diagnosis to provide that patient with tailor-made care to the best benefit of what they're looking for. So again, you have to do a comprehensive treatment approach that takes into account not just the biology, but all these various factors to minimize the potential for pain, whether it's in a neuropathic orofacial pain patient or even in a regular patient. But you got to be thinking of all the other balls to juggle other than just the biology. So what are some of the modifying procedures that we're able to do as dental providers to, shall I say, put the balance more in favor for the patient not having a reignition or an exacerbation of their existing pain condition? Well, there's multiple things that we can do. Consider patient scheduling, and we'll talk about each of these points in more detail as we move along in the presentation. Something called preemptive analgesia. The use of various local anesthetics, sometimes considered general anesthesia, certainly involve behavioral medicine, follow certain preventive and hygiene procedures that are certainly helpful and not invasive. Take a least invasive approach to doing or performing various dental interventions. Often overlooked is the potential for nutritional supplementation to assist through a more natural method of decreasing the possibility for exacerbation or reignition of the neuropathic pain. And then, of course, we'll talk about importance of communication. So let's look at these. Patient scheduling. We want to provide maximum comfort during the procedure, but not just during the procedure. We also want to do this after the procedure. So the intensity of neuropathic pain, it has a tendency to fluctuate throughout the day. In other words, there are peak times of pain and there are minimal times of pain. So in other words, there's mountains and there's valleys. You don't want to be doing your dental procedure when somebody is at the height of their pain. Therefore, if you understand the patient's pain rhythm, then you can plan the dental procedure to be done during periods of the lowest pain intensity, or better yet, if possible, during periods of remission, especially if it's elective selective procedures. You want to perform dental interventions when the medication the patient is taking to manage their neuropathic pain is at its peak level of effectiveness. So this requires the dental provider to have a good understanding of both the pharmacodynamics and the pharmacokinetics of the medications maybe they have not prescribed, but possibly those that another healthcare provider has given so that they can take advantage of appropriate patient scheduling to minimize the risk or minimize susceptibility, if you will, of having the patient having an exaggerated response to the dental intervention that's planned. What about preemptive analgesia? And you can see by this particular picture that preemptive analgesia assists with the prevention of central sensitization, and it decreases the hyperalgesia because it's, if you will, turning down the dial for nociception. So sometimes another adjunct is to administer booster doses of the anti-neuropathic medication or medications before invasive interventions. In other words, prior to the scheduled appointment, there may be a consultation between the provider of the medication that's controlling the patient's nociplastic or neuropathic pain with the dental provider to maybe load up, if you will. So therefore, you're putting more water on the fire to try and prevent any flare-ups during or after the planned dental intervention. And the dentist can then administer a long-acting anesthetic at the end of the procedure to delay any post-operative discomfort, because with local anesthetics in our armamentarium, we have both short-acting and long-acting local anesthetics depending upon the procedure that is planned to be performed. What about local anesthesia? Well, local anesthesia, the choice is related to the concentration and the duration of exposure to the peripheral neural tissue. So we have the ability to choose amongst various local anesthetics as to its neurotoxicity based upon its concentration, plus depending upon the length of the procedure. As I previously said, at the end of the procedure, potentially providing a longer acting local anesthesia to increase the post-operative time without any potential nociception is a very good thing for somebody who's got the condition we've talked about. You want to minimize an increase in pain. The clinician needs to administer the local anesthetic as atraumatically as possible. In other words, you don't want to be poking around and trying to find the right area, and therefore creating more tissue inflammation and also more tissue nociception. You want to be as atraumatic as you possibly can. Again, avoid any undue tissue to the trauma when you're doing the particular procedure as well. You want to use agents that have minimal neurotoxic effects as well as minimal ischemic effects. So you want to use the anesthetics that are going to provide the most profound anesthesia, but not cause toxicity to the tissues or the nerves. So minimal concentrations and exposure times. In other words, if you take a neurotoxic agent, and there are some local anesthetics that are more neurotoxic than others, and you provide multiple injections of this, then that's going to have a greater risk to cause a neurotoxic effect. What about if we were to do something under general anesthesia? So if you were going to have, for example, your third molars removed and the procedure is done under general anesthesia, there is benefit to have the surgeon provide you with local anesthetic of the teeth that are going to be extracted, even though you're under general anesthesia, because this has the similar principles to preemptive analgesia, where you're decreasing the potential for central sensitization as well as a decrease in the potential for hyperalgesia. Behavioral medicine is always a good possibility. In this picture, you can see 11 different relaxation techniques. Whatever works best for you, the patient, is something that you can do during the procedure as well as after the procedure. And the reason is, if you've got a ramped up sympathetic nervous system, as well as a ramped up somatosensory nervous system, we want to quiet the system down. So relaxation is very important to take a upregulated, if you will, system and downregulate it by things the patient can do for themselves. So certainly cognitive behavioral therapy or learning cognitive behavioral therapy would be of great benefit because it allows you to calm the system down. Hypnosis in some individuals can be helpful. And of course, the various relaxation techniques can also be very, very helpful in dampening down the upregulation of the sensations that are occurring, or combinations of all the above in some way, shape, or form. And whatever makes you or gets you to your happy place, if you will, is what needs to be worked on so that, in fact, we're not ramping up or stirring up the hornet's nest. And we want to support pain control or pain suppression. So whatever does it for you, you have to communicate with your dental provider that I like relaxing music. I like listening to classical music during the procedure. Or I like listening to rock music. Whatever is your magic potion should be discussed with a dental provider. Now, what about preventive and hygiene procedures? So again, we often have to modify the procedures and techniques for plaque control. We want to minimize stimulation to the soft tissues so as not to increase pain. We want this to be as pain-free an experience as possible when we are doing preventive and hygiene procedures. We do not provide procedures that will discourage or prevent the patient from performing daily dental hygiene. As a matter of fact, we want to encourage you, when you're home, to maintain dental hygiene, because if you have good dental hygiene, in other words, the prevention of the buildup of plaque and calculus, therefore you're decreasing the risk of having an invasive interventional procedure because of cavities or gum disease. Again, we want to follow a very atraumatic protocol to provide you with the best oral hygiene we can possibly create. So I'm going to show a whole bunch of different hygiene and preventive products, but I wanted to make sure I am not personally endorsing any one specific product or any one specific manufacturer. So what do we mean by atraumatic oral hygiene? Well, you can use an ultra soft toothbrush. One does not have to be scrubbing their teeth with a hard toothbrush and in a very abrasive toothpaste. As I tell my patients, we are not scrubbing floors. So an ultra soft toothbrush is something that will do the job. It will remove the plaque. It will remove food debris, but it does it in a very atraumatic manner. There's even these sponges, if you will, that can be used, or there's a product that needs to be prescribed by your dental provider called chlorhexidine, which is antibacterial and antifungal, and the sponges can be put into the chlorhexidine, and that can provide additional benefits to decrease the risk of developing periodontal disease. Interdental cleaning. So again, flossing, very important, because toothbrush bristles cannot get in between the teeth. In between the teeth is a very common location to develop cavities or gum disease. If you have larger spaces, there's products called dental tape. Or you may use these interdental cleaners, let's say under prostheses or in very wide gaps. And again, the hygienist, who's part of the dental team, should be instructing you on the use of these interdental cleaning products. What about mouth rinses? Mouth rinses can be antiseptic and they can be anti-plaque. So for example, this particular antiseptic mouth rinse can be beneficial. Or this antibacterial mouth rinse can be helpful. And please note, it's alcohol-free. Originally, a lot of these products contained a fair bit of alcohol, and now many, many manufacturers make their products, if you will, alcohol-free. We may consider using remineralizing agents. You can see in this particular picture, if you look at the gingival inflammation here, the gingiva, instead of nice, sharp, pointed areas, looks kind of blunted. It's kind of reddish around the edges instead of this stippled coral pink. You can see there's a lot of these white lesions, which are decalcified areas, which are areas that are not yet cavitation, full of bacteria, but areas that are certainly weaker and more prone to the eventual creation of cavities if something isn't done to alter the process of the demineralized areas turning into actual cavities. So what can be done? Well, we can often use agents in gels that we can put directly on the teeth, or we can take some of these remineralization agents that come in a gel and put them on a tray and then apply them to the teeth and allow the remineralization agent to soak in to the teeth to harden up, if you will, those demineralized areas. Because once a cavitation occurs, once a cavity occurs, then again, that's going to lead to a mechanical invasive intervention to remove the decay process. In other words, to remove the bacteria from that lesion and then apply some filling material to that to seal it off. Or there are actual remineralization agents. They come in the form of paste. They come in the form of gum. They come in the form of lozenges. There's a whole plethora of these available. And again, it would be up to the dental provider to discuss with you what needs to be done to prevent these areas from turning into a cavity, which then, of course, would then require an invasive intervention. Fluoride supplementation is a very good idea, and it can be in the form of an anti-cavity mouthwash. There are varnishes that can be professionally applied, and the varnish stays on the tooth because it's relatively viscous and sticky longer than the mouth rinse. Or there are even specialized toothpaste that have high strength fluoride in them to, again, fluoride remineralizes area and hardens the outer surface called enamel on our teeth and makes it more resistant to decay. What about professionally applied approaches? Well, again, it can be done with fluoride supplementation. It can either be done in custom-made mouth appliances, or what's shown on the picture here, these are stock foam appliances where the fluoride gel, if you will, is applied in the appliance and then given to the patient while they're in the chair, and they sit there for, it can be a minute, it can be several minutes, to allow the fluoride to remineralize and harden the outside enamel surfaces. Thus, again, this is all in the name of prevention to avoid that invasive dental intervention. How about scaling and prophylaxis? When you see your dental hygienist, they often take an instrument and they're, if you will, scraping the sides of the teeth to remove any hardened buildup that, regardless of how well you floss and brush, cannot be removed. So again, when they're doing this, it may be a painful experience. So there's now a product out that has 2 local anesthetics. It comes in a gel. The hygienist can apply this to the area inside your gum tissue, in between the pocket, if you will, of the tooth and the gum tissue. And this quite nicely numbs the area. So when they're doing their scaling procedure, it's not a painful experience. And of course, one can always have local anesthetic applied to, let's say, a quadrant of teeth. And again, the hygienist can go ahead and very adequately remove the hard buildup, the tartar calculus, if you will, to prevent gum disease as well as bone loss because of the bacteria contained within the tartar and the calculus. What about the dentist or the dental provider providing a least invasive approach? So sometimes, instead of extracting a tooth, one can do a crown amputation and you can retain the roots. So that's always a possibility. In other words, if a tooth may be a difficulty in extracting, in other words, it's going to be a more prolonged procedure, it's going to be less atraumatic and more traumatic, there are other ways of, if you will, removing the decayed portion of the tooth by leaving, like I say, removing the crown where the decay is and leaving the root tips. If one is going to have implants, I suggest not having the implants placed, if there are alternatives of where to place them, in the area of where the neuropathic or nosoplastic pain is. So again, site selection becomes important, and maybe select sites outside of the immediate zone of where the condition exists. Instead of maybe using a fixed device, because that involves reducing tooth structure, but maybe a removable prosthesis might be in order, or as an alternative. And again, it can also be used as a vehicle to carry transmucosal medications, which are often used to decrease the pain from the soft tissue areas because of the neuropathic or nosoplastic pain that emanates from the periphery of these particular areas. Now, nutritional supplementation is something that is not often used, but I suggest one should be looking at this. The literature is not very strong, but there is some positive literature that it may be of assistance. So when I view this, it's whatever we can get from supplementation, as long as it doesn't interfere with other medications, then it certainly should be a consideration to augment whatever management the patient is undergoing for their particular condition. So some antioxidants remove reactive oxygen species or free radicals, which are very unstable molecules and can certainly create some potential problems molecularly, possibly the use of vitamin C. And this is what I recommend, time-release tablets, about 1,000 milligrams per day. Maybe in addition to that, vitamin E, and maybe even beta-carotene. Those are all known antioxidants according to the literature. Minerals may be also used as a supplementation. And again, many of you may already be on some of these for other medical reasons, but calcium is something to be considered. Magnesium oxide, it's now currently being used in the management of migraine medication. And other vitamins, especially in the vitamin B complex, because we know from the literature that these are involved with the regeneration of nerves. So vitamin B1, which is also an antioxidant, can be helpful. Vitamin B6, because we know that it can balance out the nerve metabolism. So again, if you have an aberrant metabolism of the nerves, which is often the case when nerves are dysfunctional or dysregulated, this may be of assistance. And vitamin B12, because it maintains the myelin. It maintains, if you will, the insulation around the electrical cord. So again, this may be helpful. So these should be discussed again, either with your physician or dental provider as an augmentation to what your current medication may be. And of course, communication is absolutely important. We need communication between all the healthcare practitioners as well as the patient. So it has to really be a team approach, because you're looking for what is in the best interest of your patients. You have to certainly appreciate and respect the patient who is experiencing this neuropathic orofacial pain, and you have to understand the patient's tolerance for potential painful interventions. We are all built differently. We all have different physiologies. Some people, all what I've said today may be of no value, and to others, it may be of great value, because everybody's tolerance, both physically and mentally, to interventions can be quite different. So again, if you've been seeing a practitioner for a period of time, they would have a good idea in their minds as to what your tolerance may be. So it's important, know the rules. I cannot understress or overstress the team approach. Everybody has to be on the same page, and therefore that will provide the best benefit for the patient in a tailor-made, personalized medicine approach, not a boilerplate, not the same for everybody, because we're all different. So I hope this has been helpful to you next time you visit your dental provider to discuss these issues with him or her and involve your physicians in terms of developing a team approach to assist you with the management of your condition. So that's my presentation. I will certainly answer any questions or comments or have a discussion on the material that I presented.
Thank you, Dr. Klasser. We don't have a lot of time. I just wanted to make sure, I'm going to ask you one question. I think to me, it's the biggest question. It's kind of the question we get the most and we have discussion on. But yeah, if you could share your contact information. Thank you so much for allowing people to contact you. So here's the big question. Why don't more dentists know about trigeminal neuralgia? Because there are so many people in our community who have pain and their dentist did not recognize that it was a neuropathic issue.
Excellent question. And I'm going to give a very sad answer, unfortunately. I'm an educator, and it's my task to educate all the students who I hopefully have a positive impact upon about all various conditions outside of general dentistry. Fortunately, at LSU, they have somebody like myself. There are other institutions who also have other people like myself who try and broaden the scope, if you will, for dental education. My view is dentists should be considered physicians of the oral cavity, meaning that, yes, we mainly deal with teeth and gums, if you will, but there's a lot more to being a physician of the oral cavity than just a keeper of teeth and gums. So we here, all our students should understand about trigeminal neuralgia, or I would say even broader, neuropathic nostoplastic pains. Unfortunately, I can't say that is universal. There are many, many institutions who basically take the viewpoint dentistry is all about being and I'm going to use a negative term here, so I apologize, a dental mechanic, and everything has to be mechanical. You have to have a handpiece or an instrument in your hand to be doing a mechanical procedure. We hope that that's changing over time. We hope that organizations like the Facial Pain Association can bring light to institutions that dentists should be more. I applaud the association for having individuals like myself and others who have a dental background on their board, understanding the important component that dentistry plays. Changing paradigms is very difficult. We are trying our best to change this paradigm, and it's really sad when many trigeminal neuralgia patients get misdiagnosed and have multiple dental interventions performed by, I believe, well-meaning practitioners who never got a lecture throughout their entire dental careers on trigeminal neuralgia. So you are correct. It's certainly a shortcoming in our educational system. And hopefully through efforts like this organization and others, we can change that. So the next generation of patients who unfortunately suffer terribly from trigeminal neuralgia will not be, and I'm going to use a strong word, harmed by their dental provider, but actually assisted by their dental provider.
Thank you so much. That's a good way to end it. And we appreciate your efforts on that front for sure. So thank you very much.
And thank you very much for allowing me this platform to hopefully educate the patients there that there are many, many, shall we say, strategies that can be undertaken to assist in the management of your pain. And the dental individual, your dental team, should be part of the team approach. So thank you very much. Have a wonderful day. It's been a pleasure.